Over a half century of runaway fee-for-service, 7 years of Obamacare, Republican leaders with inept efforts at reform, and now a president whose solution is to sell health coverage across state lines, and it will bring premiums down 60 to 70%. Is that the best we can do? Can it truly be possible that our past and present leadership has failed, and it's failing now to properly lead us into any kind of reasonably sustainable solution? Today, we jump into reality and reason with renowned healthcare scholar and pedigreed economist Joe Antos of the American Enterprise Institute. Hop on the train to reason right here on Red Hot Healthcare. Let's go!
3 alarm and 21 and north. All engines respond.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com. This is Dr. Steve Ambrose. As a healthcare influencer, I'm in contact with some of the brightest minds and most powerful leaders in the industry. But my best effort comes from outside the booth. Knowing how to engage patients is an art, science, and philosophy that I know very well. I'm a hired gun that brings expertise to healthcare organizations of all types. You've heard my words. Now read my thoughts on my free white paper called The 7 Mistakes Made in Patient Engagement. Just go to redhothealthcare.com/learn. That's redhothealthcare.com/learn. While you're on the site, dive into my consulting and speaking services and schedule an initial call. You won't regret the uniqueness, benefits, and results I can deliver for you. And now, back to the show. Welcome, everybody. This is Dr. Steve Ambrose, and I want to thank you for coming onto the show. Today, we have a great guest in Joe Antos. He's the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. His research focuses on health policy, the Affordable Care Act, Medicare, the uninsured, and also the overall reform of the healthcare system. Now, before joining AEI, Joe was the Assistant Director for Health and Human Resources at the Congressional Budget Office. He also held senior positions in Health and Human Services, the Office of Management and Budget, and the President's Council of Economic Advisors. Hey, Joe, a privilege and a pleasure to have you on the show today.
Thanks very much.
I want to jump into the meat of matter, give you my strong point of view, and I'd like to get your reaction to it. In looking at healthcare, perhaps maybe from a non-economic perspective, one of the things I see is that there really seems to be almost a direct opposition between the business of healthcare being largely focused on profits and then the needs of the healthcare system, where we talk about consumer affordability and quality of care. At times, it seems like they're just not in working alignment. What do you think about that concept, and what do you think about the fact that there may necessarily be diametrically opposed forces here?
Well, I'm not sure they're diametrically opposed, but certainly politically, we haven't seen really very much discussion about the delivery of healthcare. The Obama administration primarily focused on expanding coverage and financing health insurance, not delivering services. The debate so far this year with Republicans has remained on that ground. In other words, how do we change the financing system rather than how do we improve the way healthcare is delivered, and how do we improve the connection between what people need and what they can get?
I'm not really a decent armchair economist, and I know certainly you are an award-winning economist. I wrote a recent article, Joe, focusing on Kenneth Arrow, who you probably know of. He was also serving on the President's Advisory Committee like you do. And back in the 1960s, as we both understand, he was an integral part of Medicare's creation, and more than that, also creating the fee-for-service payment system established in 1965 and started in 66. One of the things that he wrote in a landmark paper which wound up getting adopted as part of Medicare Start, was that free market forces, as they work in other industries, really couldn't work effectively in healthcare, and that the government really had the chief role in regulating the industry. Looking back on that, Joe, as an economist, do you believe that we should have started Medicare with perhaps maybe a blend of government regulation and some free market forces, or maybe just had entirely free market forces from the beginning?
Well, that's difficult to say, Steve. I mean, it's hard to go back 50 years and imagine what could have been, but certainly on Ken Arrow's point, that was from the perspective of the early 1960s. He's a great economist, but like most economists, he wasn't good at predicting what was going to happen 50 years later. So, in fact, we have a very, very different set of circumstances. For example, one of Arrow's major points, which is absolutely valid, is something called asymmetric information. What that means is that I, the customer or the patient, know a lot less than the doctor about what my illness might be and what the alternative treatments might be. There's another asymmetry that I think Ken Arrow didn't really focus on, but it's just as strong, which is that none of us know what it's going to cost. That's another small problem in information.
Yeah, agreed.
Exactly. But the reality is that we are now in an information centric age. We are now, thanks to modern technological advances, thanks to the internet. If I get a diagnosis for something and I want to look into it, I can go on the internet and I can, if I'm careful about where I look, I can find quite reliable information about what does that mean? What are the likely consequences? What are the likely treatments? Of course, I'm not going to treat myself. I'm going to go back to the doctor, but I'm going to be a much more informed patient because of that. If I'm careful. Now, of course, I could easily be foolish about this, go to some wacko site and imagine all sorts of things that don't seem reasonable, but it's not that hard to find good information on the internet. And for that matter, if you're a nerd like me, you can read the New England Journal articles, you can read the medical journal articles and hope that you understand them, or at least you can go to your doctor and say, what do you think this means? Explain it to me. So from that standpoint, that information asymmetry, which is still there, is being chipped away. Similarly, on cost, there's a lot of angst about what things cost. People can now find out to some extent by going to their insurer's website. Insurers have caught on that you have to tell people a little bit about what their insurance covers and to some extent tell you something about, where are you on your deductible, for example. This all could be improved a great deal. We've gone a long way from what Ken Arrow is talking about. Now, one other little side point. When Medicare was created, in fact, it started with a joint government program, but largely run by private insurance companies. And it's still true today. The reason for that is the government in 1965 and still today really didn't have the capacity to process all of those bills and to send out, individual little checks back in those old days when they were paper checks and now it's electronic, but it's still the same principle. You have to be able to process literally millions and millions of bills from hospitals, from doctors, try to figure out how the insurance works. Even Medicare is very complicated. It's not a simple system. Figure out who gets paid, how much the patient owes, and so on. The government can't do it. It has never been able to do it. It never will do it. Medicare is, at least in terms of administration, is largely run through the private insurance system.
A lot of great points with that, too. One thing I'd like to add and get your take on also, too, Ken Arrow also back then said that we should really leave the decision-making and the pricing to some degree in the doctor's hands. The understanding was back then, and maybe that the rope that was given to those doctors was that doctors were going to altruistically put the patient's needs ahead of their own profit needs. And, surprise, surprise, many doctors wound up actually billing Medicare, billing much higher than Medicare. And what was very interesting, a lot of people don't remember was when it first started, you didn't have to go ahead and accept what Medicare paid in full if you were a doctor, right? You could bill over and above that. So maybe you could speak to that a little bit about maybe sort of the rope that was given to the providers in the beginning in terms of the trust that they weren't going to go ahead and overbill the system, and maybe how maybe some of that trust has been misplaced.
Sure. So I think there's a learning process here. I'm now going to reveal something about my age. For your older listeners, they remember Marcus Welby, MD.
Yes.
Remember that? And this was a doctor who visited you in your home. Now, that hasn't happened in, I'm going to be careful about this and just say a few decades.
All right.
But in reality, in 1965, when Medicare was being created, or really before then, when the negotiations were being made, it was really a different way of delivering health care. It was not high tech at all. There was a limited range of pharmaceuticals. There were very few fancy diagnostic tools. Basically what Marcus Welby had in his bag was what you needed. It really was a different situation. There was a more personal relationship, I really believe, between patients, certainly older patients, and their doctors than we often see today. I want to give the folks back 50 years ago a little bit of break, that they couldn't possibly have anticipated what we see now. The fact is, however, that healthcare, while it was a business then, it's a big business now. We've had tremendous amounts of consolidation among providers over the last 50 years, but certainly over the last 20 years, big time. We've seen individual physician practices being bought up, sold by the doctors to the local hospital for lots of reasons. And so, the reality is that it is now a big business, and it is far more impersonal. And in that regard, we've got to have a better way of looking at the way the world is now rather than the way the world was then.
Looking at the way the world is now, just to bring that last comment into this next question, and I'll just be very plain speak about it. I think that, for 7 years, we've heard all the complaining, all the moaning about how terrible Obamacare was for the country and for healthcare, and I'll go on record as agreeing with them. But look, when it came time for the Republicans to put together a suitable solution, it seems as though they were either asleep at the wheel or they just didn't have a solution that could work for the masses. And I don't think there's necessarily a simple solution, by the way. But I also think, too, that just as a leadership and in preparing for this, they seemed unprepared when it came their time to bat. Why do you think this happened?
Yeah, I agree. They were unprepared. That isn't to say that individual Republican senators and members of the House weren't working on these issues. They certainly were. There were a fair number of bills introduced over the past 7 or 8 years, basically after the Affordable Care Act was enacted. But even before then, when it was being discussed, there were Republican ideas. We certainly saw this very frequently in the Senate. Senator Tom Coburn, when he was in the Senate, was a major figure in developing a host of different legislative proposals that, of course, weren't going to go anywhere because Republicans weren't in charge and Democrats were headed in the direction that they were heading. So part of the problem was, for 8 years, Republicans felt that they didn't have a voice. Part of the problem is that, and this is a big part of the problem, that Republicans really got into this game fairly late. When you think about Democrats, experts with a more kind of liberal bent in healthcare, you can think of lots of people, right? It certainly goes back to at least 1992 when Hillary Clinton was unsuccessful, but she had organized a massive effort, government-wide, brought in lots of people for what was called Hillary Care. It didn't go anywhere, but there was a 2-year period when there were a lot of people working on this, and many of those people who were junior people at that time became senior people in the Obama administration. So they were more than fully prepared. They had a clear direction where they wanted to go. What were Republicans doing? Well, Republicans were basically worried about other issues. Last year, Paul Ryan, seeing that their candidate wasn't going to talk about policy, put together an effort for House members called A Better Way. They had a Better Way plan for healthcare and a bunch of other issues. That was not intended to be a legislative agenda. They didn't know where Donald Trump was coming from. It was meant to give House members who were running for re-election, Republicans, something to talk about. And I think that was successful for that limited purpose. But that wasn't the blueprint. There really wasn't a blueprint. And I think the leadership, if I were to blame leadership, I would start with Donald Trump because he just didn't come into office as organized as most previous presidents have been.
Great point. As we move into that topic on President Trump, I find it, maybe from an outside of politics perspective, Joe, I find it really interesting that, President Trump is certainly not a healthcare expert, but as he says, it was going to be so easy to give people great health care at a tiny fraction of the price. And even he was starting to talk about selling insurance, health insurance over state lines as a solution. It was going to bring down the cost of care. Most economists, and I think most people that have a sense of how healthcare does work and how it's priced, really know that that doesn't make much sense, actually. It seems like the media bought that. The citizens bought it. The supporters bought it. And we saw this also with Obamacare, right? Several years ago with Jonathan Gruber, the architect of Obamacare. And even when he commented, and they caught him commenting on the stupidity of the American voter, helping President Obama pass the Affordable Care Act. It seems like to me that we should have as citizens a responsibility to be more literate on healthcare policy. Certainly not to the degree of someone like yourself, but I think because we're not literate, and the media seems to not be literate, it almost seems as though it is sort of a dumbing down, as it were, and the media and citizens have been the unfortunate recipients of that. What are your thoughts?
You never ask an easy question, Steve. I have to hand it to you. So, there are a whole bunch of issues here that you're really addressing. Part of it has to do with should the average citizen know more about how health policy is made or what the issues are when people in Washington talk about changing health policy. And I would agree that that would be useful. I think the electorate should be more informed about everything. Let's face it. However, when you think about how the average person really interacts with the health system and interacts with Washington policy, well, the reality is that they interact with the health system through their family doc. Most people hardly interact at all with Washington policy. They get interacted on. You pay your taxes. I would say that's not something that you like to do, but you have to do it. Things change, you live with it. But in terms of really, being actively involved, that is, speaking of elites, those are the elites. Those are people, they may not live in Washington. They may not, live in your town necessarily. Of course, people in all of our big cities there are lots of people who are interested in all of this stuff. But in terms of the real activists with regard to policy, it doesn't happen out there. You can have all the demonstrations you want. You can shout down your local representative as much as you want. Doesn't make much difference. Policy is made in Washington. It's not made in town halls. It's not something where the average person has a great deal of leverage or interest, for that matter. When I talk to my relatives about this, what do they want to talk about? They're marginally interested in, what's going on in Washington, but we quickly turn to what are we doing for vacation? How much is it going to cost to send the next kid to college? Practical questions, practical issues that people live with every day. That's where they're coming from. Now, policy is one thing. Interacting with your doctor, interacting with the health system is really where it's at for people. They need better information about what their options are in insurance, what their options are in terms of providers, what their options are in terms of treatment, and what their options are in terms of cost. All of those things are really necessary. That's something that the average person could get behind if they could get this information in a way that they could understand.
On those points, I agree with you on. I probably would take a little exception to the fact that healthcare has become largely unaffordable. And I know we disagree a little bit on the statistics for sure, but I think if we just look by and large, the number one issue that people have with healthcare now doesn't seem to be, and I'm talking about the patient, doesn't seem to be the quality, although the quality needs to be improved for sure. It really seems to be the cost. I mean, you could be talking certainly about the cost of drugs. You could most definitely be talking about the cost of healthcare coverage, and Obamacare has made that more than clear, right? And this leads me into a point that I wanted to ask you about. Being an economist, I've been sort of biting on the bit to ask you this. I've talked about in my prior podcasts, even in my prior authored articles, about the fact that I notice just how much everybody's talking about healthcare costs, right? Joe, we have to bring down healthcare costs. We talk about dropping healthcare costs, but I never hear the second half of that, which is, okay, if hospitals can drop healthcare costs down, and let's say payers can drop healthcare costs down because they're going to get more efficient, we're going to pass that on to consumers in the form of lower prices, because after all, prices have skyrocketed. And not only are prices skyrocketing, now deductibles are skyrocketing on top of the prices skyrocketing. Why is it not reasonable to expect that pricing would come down? Why is it that we don't think of healthcare or expect healthcare businesses to value their consumers in a way where they would want to eventually start competing on price?
And those are the magic words. What we need is a consumer-centric system that is actually competitive, and we don't have that. So both Democrats and Republicans like to talk about the exchanges, and you're supposed to get choices. And now that Republicans have supposedly fouled things up, they're down to only one choice, which is not going to be a competitive choice. And there's some validity to that. But even if you are in a market where there are different insurers, those insurers are buying services from the local health sector, and in particular, the hospitals. And certainly all the big cities, there is a dominant hospital. The city I like to pick on a little bit is Boston, but it's true in Washington, it's true in Baltimore, it's true in all the big cities, and probably smaller cities as well, by and large. And that is, in Boston, you have Mass General. If you're an insurer, you have to have Mass General. You have to offer Mass General on all of your plans. Why? Well, it's because Mass General has a deservedly good reputation, and all your customers want to be sure that if they need something special in the hospital, that they can go to Mass General.
Right.
That puts Mass General in a position of being able to name their price, which they do. And although there are in Boston a number of really great hospitals, in addition to Mass General, they can lower their prices. They do compared to Mass General. Nonetheless, there isn't that much to be gained by considerably lowering their prices because of the obvious way customers seem to think about where they should go to for the hospital. Net result is that you have a system where there's very little competition among providers, even when there are plenty of insurers, because all the insurers are hooking into the exact same health system. Now, that said, we've seen lots of consolidation in the market as well. Certainly in the big cities, the major hospitals buying up physician practices, buying interests in post-acute care settings, nursing homes, that sort of thing. So we have a very consolidated market on the supply side. In smaller places, there may not be that many insurers, so it's not a great competitive situation there either. That's a real problem, which we're not going to be able to solve simply by waving a magic wand and saying it should be better.
Yeah.
Talking about competition is one thing. Having it be real competition is really another matter.
Yeah, what a great point. And also the second half of that too is that demand is up. Everything's consolidating and you have mass demand. So really, they don't even have to compete. The demand is there. People are lining up for services. It makes for kind of a nasty stew when it comes to keeping things affordable. But let's move to transparency. Earlier this year at HIMSS, I attended an event, Joe, where within HIMSS, they were talking about pricing. They were talking about consumerism. And I won't mention who it was, but it was a chief marketing officer at one of the largest health systems in the country. And he said, yes, we're really helping our consumers. We're making prices much more transparent online. And I went up to the mic and I asked him, I said, what are you doing about affordability? And this sort of feeds into the last question too a bit. And he said, what do you mean? I said, well, the fact that you're making pricing transparent is certainly nice. It's better than not doing it for sure. But that's not the same thing as making it affordable. I know that one thing Republicans and Democrats do agree on very much is stronger laws relating to pricing restrictions and transparency on drugs. And I'd like to get your thoughts on where you think this ends up.
Let me hit hospital price transparency, which is sort of where I think this initiative got its start. I think the theory was that hospitals would be able to tell everybody what it cost for an appendectomy, the hospital portion of it, not necessarily the physician part of it. And they could, because they have list prices. There's no question about it. However, for almost everybody, including most people who don't have insurance, but certainly for people who have insurance, the relevant number for them is not the list price. It's the price they pay out of pocket. It's the amount that they see, that they feel they're paying. That really has a huge influence on how people think about what it costs them to get treatment. To make an analogy with kind of routine doctor's visits, it's not the $100 for the visit. It's the $20 copayment that really gets people's attention. And that's sort of what's going on throughout all of this. With drugs, it's even more complicated because there's tiering. There are formularies. And so, a drug supplier might very well tell you the transaction price, whatever drug you're taking, the full transaction price. That may even show up in your statement from your insurance company. But what are you going to pay? Well, it depends on where is that drug on the formulary. It might be on the level of the formulary that they are encouraging you to use those drugs, so that your copayment might be very low. But even if it's not a very expensive drug, it might actually turn out to be very expensive for you if it is placed on another place in the formulary where you end up paying most of the cost because there's a competing drug that has made a better deal for the insurer. And they want to basically steer you to that better deal for them.
Yeah.
So it's really not a clear situation at all. And if you were speaking to someone representing a drug company or a supplier, he's only one part of a very complicated pricing system.
Yeah. One of the things that we talked about this off air too, Joe, such a complex system. I mean, you've got retail pharmacists, as you mentioned off air, PBMs, physicians, and that really everybody has a hand in this, except it seems like the consumer. It seems like the consumer that everything trickles down to ultimately has zero leverage. And if you look at even the pricing now, I'm trying to think of the number, but I believe the average specialty drug is something like $100,000 a year. I'm talking about specialty drugs now. When the push is on them to ask, well, how do you substantiate this? They seem to come back with the same answer constantly. Well, it's our R&D. It's our R&D costs. We need to make sure our R&D costs, they're high, and we have to keep that in place so that we can keep making better quality drugs. Yet, a lot of the drugs that seem to come out of drug companies these days, Joe, I mean, they're not really blockbusters. That, maybe a new cancer drug that costs $140,000 a year, but it maybe adds a month and a half of life on to somebody dying of cancer. And then the question becomes, what's the justification and the benefit? So when you're looking at transparency, one of the things I start to think about is, do drug companies really make all their books and all their line items and really the value transparent?
If you're in business, you can't possibly give away all of your business secrets, these are basically trade secrets. The negotiations and so on are very complicated, and they do need to be confidential. Your point that the consumer has very little leverage is right, because we're not really consumers. They call us patients for two reasons. One is we patiently wait in that little room with the door closed.
Yes.
Right?
Yeah.
But the other reason is that we are not consumers in the sense that we're paying the full shot, and that they is the hospital, the doctor, the drug company, the insurance company. We're not the primary payer and the primary decider in so many cases. For those of us who get our insurance from employers, the insurers are not selling to the individual employees; they're selling to the HR director. That makes sense for all sorts of reasons, but the result is that the individual person is not a consumer like they would be if they're going out to buy a cell phone.
It's like almost like they're not both the customer and the consumer. It seems like to me, really, that the payer is the customer. The payer is really the customer, it seems, the paying customer, as it were, of the hospitals, health systems, and the drug companies. And the patient, though they consume healthcare, really has to bow to the pricing that was set by the payer. Now, of course, they have to support the payer, as you know. Everything trickles down ultimately to the consumer or the business consumer, but they really don't get a say-so in what level of payment is going out. And I like to make this analogy. It's almost like you and I go out and we have lunch, and somebody's paying our lunch bill for us. And if we go back and say, hey, listen, if we went to this place for lunch, it was going to cost $85 for us to get two really nice lunches, but we found the same lunch for half the price. And the people paying the lunch say to us, it doesn't really matter. Just go wherever you want because we're paying the same price anyway, virtually the same price. That's what it feels like. It feels like even if the consumer ultimately wanted to help the payer, it's almost like the payer doesn't even want it. The payer's not programmed to even benefit from it.
Well, so this is really one of the arguments behind health savings accounts.
Right.
The idea there is typically you have a high deductible plan. The deductible might be $8,000. It might be higher than that, might be a little lower. But if you had a health savings account to help you cover that initial cost before the insurance kicks in, then the idea would be precisely that you would be very aware of the cost. You would be very interested in the price. And you would be careful about questioning your physician. Do I really have to come back next week for a routine office visit? Does it really make sense for me to get an MRI when a sonogram, which was less expensive, you said already diagnosed my condition? What is the purpose of the MRI that is far more expensive? It's those sorts of things. Or if it's got to be an MRI, is there an MRI facility that won't charge me as much as the one in the hospital? And there, by the way, often are. You'd be a lot more aware of the cost. There'd be a lot more pressure on all of the providers and on the insurers to in fact tell you what the price is. So that could be a revolution, but that's not a revolution that happens overnight. It's going to take a while to get there. And I think we're headed in that direction. As much as I think the ACA is wrong, and in particular on this point, it's very wrong, but all those plans are high deductible plans. What they failed to do was say, hey, we've got to help these people with their deductible. Let's set up a health savings account. That's a part of the ingredient that's missing there. And that's one of the reasons why so many people who thought that the ACA was going to be good for them are quite unhappy. Well, I think we're moving in that direction because you see everywhere, employers are looking at healthcare costs and saying, we can't do this. As you said earlier, we've got to carve out some of this money and give it back to our workers in the form of wages because we're going to lose the good workers and we cannot afford to do that.
Right.
So you add all this up, we're moving in a reasonable direction. It's very slow and it's going to be very painful, but we're going to have these institutional changes. And we're going to have them you're a young man. We're going to have them in your lifetime.
We must have never met personally. I guess I don't think we met personally. That's why. But thank you. I sound young. To that point, I will just mention this, and then we're going to certainly close things in on the interview here. I had a gentleman on my very first show named David Goldhill. He's the CEO of a company called the Game Show Network. They go out to about 80 million people. He's not in healthcare, but he wrote a book called Catastrophic Care, Joe. And if the audience hasn't read this book, I would recommend reading it. It's an eye-opener. But he looks at healthcare, as a CEO, but also from an outside perspective. And one of the suggestions he made towards reforming healthcare is he said, and this sort of tails on your point a bit, Joe, that he would like to see, whether you call it Obamacare, whatever it is, a safety net insurance that, let's say, has an $8,000 or $10,000 deductible, but that the rest of it, that everybody in America has a pre-funded health savings account, every man, woman, and child. And basically, the first $10,000 a year, or whatever it might be, is paid for by people, that the payers don't pay for that. The doctor's visits, the drugs, that sort of thing, unless they fall into catastrophic care classification. And all of a sudden, if you take the payers out of paying the first $10,000 of it, or the first $5,000 of it, you start to realize that, like you said, Joe, people start paying out of their own pockets. Now health systems and drug companies and hospitals are going to have to really take that into account and say, wow, we better be more competitive on pricing and cost. I'd like to get your thoughts on that, maybe a blended system like that. And then, a second part of that might be your thoughts on how you might go about reforming healthcare just on a very high level.
So on David Goldhill's book, it's really great. I've actually worked a little bit with him on the New York State's healthcare system, and so I got to know him a little bit. And he's right. I think it's a matter of scale more than anything else. When enough of us get there, when enough employers say, this is the way to go, and believe me, employers are moving in that direction fairly rapidly now, a fairly high percentage of plans now. The options include a so-called consumer-directed health plan, which is a high-deductible plan with a health savings account. So I think that's the direction we're going to be going. And as I say, it's just a matter of getting enough of us there so that we represent a real economic force. Moving to your other question, though, about, what should we do and how should we do it and where should we go? As much as consumerism is important, the government has a huge amount of influence and a huge amount of control over the health system, and we need to look there. The Medicare program in particular, it's 100% federal. It's not a matching program with the states or anything. Of course, it is a program for senior citizens primarily. And who are the biggest users of healthcare, appropriately so? Senior citizens. And so if there's leverage in the market, Medicare has it, not only economic leverage, but also regulatory leverage. And so what we really need to do is go back to Medicare, which is another big disappointment for me personally. I've been banging this particular drum for a long, long time, that it's really Medicare reform that is going to not necessarily lead the way, but at least not continue to slow the progress towards a more efficient and effective healthcare delivery system and a smarter financing system as well. So I would start with Medicare. I would look at the rules that they have. The payment systems are largely a mess. Medicare still largely depends on fee-for-service without any thought about helping the physician or the patient understand what the options are, without helping the health system do a better job of managing what is often a very complicated case for delivering care for the patient. We just don't have enough sensible management because the financial incentives are not there. And the Medicare program basically is pushing inadvertently against all of that. I would start there. Medicare could do a lot to push for understandable information for consumers. When you turn 65, you have lots of options with Medicare. The good news is that a lot of people sign up for private plans and Medicare Advantage because, frankly, by and large, it's a better deal. And it's also the kind of plans that most people now turning 65 have had their entire working lives. But figuring out what the options actually mean and what is the bottom line, what is it going to cost me, looking at all these different options, fee-for-service with or without Medigap, Medicaid factors in here. Medicare Advantage factors in here. Do I buy a separate drug plan? It's all unbelievably complicated. Medicare could do a better job of that. And it has the bandwidth. It has the money. It has the market share. It has every reason to do these things. So that's where I would start. I think continuing to work on smart regulation and smart deregulation is also where it's at. I think the biggest thing that the government can do for all of this is to get out of the way, stop locking us into the mistakes we've been making time after time after time, and open the door more widely to innovation at the state level, innovation among insurers, innovation among health plans and health providers, and innovation among employers, which I think is ultimately going to be where we're going to see the greatest action. Big employers are already taking, I think, wise steps to try to get control over costs without cutting into the value of their benefit, because again, that's something that affects their bottom line and it affects their workforce. So they have the clearest incentive to take actions and to do things that are going to make the system better for everybody.
Joseph Antos, the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute. Joe, I want to thank you for coming on Red Hot Healthcare. An absolute privilege and pleasure. It was great having you on and speaking with you, and I look forward to doing it soon.
Thank you very much, Steve.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.